Thank you, Anna. So thanks everybody for joining us today. And I especially want to thank all of the states who have helped put together that RUS package. Everybody submitted data and explained their data, and we went back and forth a few times. So I really appreciate everybody's efforts in helping us make sure we had that squared away. Having been a part of submitting data to the RUS group or as a package, I am expecting that we will all see maybe some follow-up questions or, as part of the data evidence review. So don't be surprised if they get in touch with you about any of your data that was submitted. That seems to be something they do. So I'm going to just go over the New York State's update. This is just to give you an idea, all the states had a fairly similar template here. So I think most of us will be showing the same slide. It's relatively straightforward, and you'll see a repeating pattern here. So New York State, we started screening back in 2006, and things have really changed a lot. Back then, we were our primary screening method was flow injection analysis, which it still is to this day. For most of the time, we were not refluxing our analysis to Cycasine. So I think most of you know that Cycasine has really improved newborn screening for Krabbe disease tremendously. And this is kind of the nature of the process of a continuous improvement. And as states come on, we're hoping more and more states will be able to implement Cycasine second-tier screening, which would really improve or decrease false positive rates that we're seeing, we had seen through screening initially in New York State. And a lot of times people remember that data. And it's like, we have to continually remind people that was old. That was back in 2006 till, maybe 10 years worth of information. The things, since then really have improved, and make sure, these people understand that, because that's where things often go. So to date, we screened about 3.7 million babies. Our infantile Krabbe diagnosis is 9. We have a symptomatic late onset baby who was about, I think, 4 years old or so when the child was determined to be symptomatic and was transplanted. We've identified, this is a point I want to clarify. In the past, we use at risk to be based on just David Wenger activity. And depending on what activity it was, we had defined high risk and moderate risk. And at one point, we even had low risk. Well, that's been modified with a recent paper by Dr. Robert Stone in how we evaluate what the risks are. So the Krabbe Consortium group that you heard about from Anna is a group that can really help with identifying or defining the risk of a patient for anybody detected through newborn screening. So if there's any questions with state labs and how we evaluate cases, that's the place to bring it up. We have a special session on that where we do case review. And for those states that are new to it, this is a forum for, to get an idea of how those cases are actually defined now that we have a better system of doing that. So New York used to have a little bit higher number of what we thought might be late onset patients, but this is based on a combination of Cycasine and genotype, and using the risk assessment tools provided in Dr. Robert Stone's paper that have been renumbered, just so that for those of you who might be wondering, how come that number is 40? Anyway, that's where we got to it. So one of the things, the questions was, what's the algorithm for informing babies and parents of a positive test? Well, in New York, this is a process we use for all newborn screening, especially for inherited metabolic disorders. We're referring to a metabolic physician in working in parallel with a pediatrician if we have a pediatrician of record to inform the family. So the newborn screening program isn't actually informing the family, but works with the metabolic center physician. and or pediatricians to make sure that message is properly given to the families.